Welcome to QD Clinic. Hi, I'm your host, Jack Cush. Today, we're going to talk about swollen but not painful. ACR 2020 is coming up. It's a virtual meeting. You give us 2 hours, we'll give you the meeting. Swollen, not painful. What's he talking about? I'm talking about a 61-year-old white female who shows up in my clinic a few weeks ago. She comes in with a complaint of bilateral pain in her feet, meaning her ankles, really meaning her midfoot. It's going on for about 5 or 6 years. Started off with an insidious onset of some difficulty, not a lot of pain, not a lot of swelling. There's no redness or episodic attacks or anything like that. What she notes is that, her feet kind of bothered her, and it's only been recently that they've really bothered her, but they've bothered her because she's developed more and more of a neuropathy over these 5 years with numbness and tingling, occasionally burning. Never had an evaluation for neuropathy. And now the feet are bothering her because she has bony abnormalities in the midfoot. And the question is, what's going on? She's sent with a possible diagnosis of gout. So what's her past medical history? Osteopenia, vitamin D deficiency, colon cancer that was well treated. Now she's doing fine with all of those things, taking very little medicine, not taking any medicine for pain. When you do the exam, she's got a bizarre midfoot bilaterally. She's got hypertrophic bone at the tarsometatarsal joints that's very asymmetric, even though it involves right and left side. And again, it's a bizarre looking foot because of, again, this bony overgrowth. Clearly what I'm describing is someone who has a neuropathic joint. And why do I call this a neuropathic joint or arthropathy? Why is this Charcot arthropathy? Because of what I introduced at the top of this segment, swollen but not painful, meaning you get bony, hypertrophic derangement, but not much in the way of pain, and often in the presence of neurologic damage. So what happens in folks with Charcot or neuropathic joints is that because of the neuropathy, there's a loss of proprioception, and they end up just having a repetitive trauma to those joints. Proprioception actually protects you from a lot of damage, but the loss of damage, they get the pounding that leads to hypertrophic bone. This is very common in diabetics, where there's involvement usually of the TMTs. It's also common in patients with syphilis. There it's called tabes dorsalis, where the involved joint is usually the knee or hip. And then bizarrely and uncommonly, rarely, is syringomyelia, where the shoulder, elbow, and sometimes cervical spine can be involved. There are other causes, calcium pyrophosphate disease, alcoholic neuropathy, amyloidosis, and yaws. You have to look that one up. So what happens is early on they can develop an acute neuropathic arthropathy with effusions. And effusions are usually non-inflammatory. They're occasionally hemorrhagic because of the trauma. But then most people, by the time they present as this patient, they have chronic disease with chronic damage that looks like exaggerated osteoarthritis on radiographs. Again, the key here is that there's not a lot in the way of pain. There's not a lot you can do. Weight loss, they need pain medicines. You give them pain medicines. Splinting may work. Not surprisingly, they don't respond to much. They don't really respond very well to surgery. Arthrodesis doesn't work. Joint replacements are usually problematic. Again, they suffer from a loss of proprioception, and that's going to continue. So the main thing is to make the diagnosis. What is the cause of the neuropathy? What is the cause of the neuropathy that leads to the Charcot joint? Not apparent in this patient. She has no history of diabetes. Her recent blood sugar looked to be normal when I looked at it, although we sent off labs, haven't seen them yet, including a hemoglobin A1C, an RPR, and other tests looking for neuropathic causes. Could she have amyloidosis? Well, then you're going to have to get a fat pad biopsy. But again, I think we have to sort of go through a process here to make the diagnosis. Until that time, it's about really making the diagnosis more so than keeping the patient pain-free because they came in pain-free. I think in this particular patient, we did refer the patient for nerve conduction studies to look for and to document the neuropathy and the type of neuropathy she has. So these patients are interesting because they are uncommon and they can be readily diagnosed on clinical grounds. You can say a lot about what happened. You can't necessarily do a lot about what's going to happen in the future. Again, give us 2 hours. We'll give you the meeting. Tune in for more QD clinics.